This is Ginger Keene. We will be discussing atrial dysrhythmias in this context. The objectives: we're going to identify the EKG characteristics of dysrhythmias that originate in the atria, discuss the concepts of prematurity as it relates to cardiac rhythms. We're going to examine re-entry as a cause of dysrhythmias and the hemodynamics consequences of selected atrial dysrhythmias and the clinical management of patients with atrial dysrhythmias or tachycardias. Origin of rhythm, we already discussed SA node. Now we're going to talk about the atria. We're learning about the characteristics of beats originate from the atria. A new term you may hear or you may already know is what we call ectopic. Atrial rhythms are considered ectopic rhythms, which means that they originate outside of the SA node, but within the atrium. Beats that originate outside the SA node don't look the same as a sinus beat. So they don't have the P wave that looks all the same. They don't have uniformity. So in this slide, this illustrates lead 2. And the normal depolarization, again, starts from the top of the atrium and it works its way down from the negative to positive. So these are all going to be positive deflections. And then it goes down into the ventricles, throughout the ventricles. So that's how your conduction is. And again, if it was a deflection away from the positive to the negative, it would look upside down. These are examples of atrial arrhythmias. When we're looking at these, we're going to analyze the P waves, which is critical to identifying atrial dysrhythmias. So looking at the different types, you might have P waves that look slightly different, such as in this first slide where you have P waves that all look kind of different. So they are taking different pathways within the atria, but these are coming from the SA node. And we'll talk a little bit more about that. Some of them look a little squiggly or inverted, or you can't even see where the P waves are. They're all up in the T's, or they may have sawtooth or wavy baseline. So these are the different types of atrial arrhythmias we're going to talk about today. The causes of your atrial dysrhythmias, usually it's due to an alteration in your automaticity, an increased automaticity within the atrial cells, or a decreased automaticity of the SA node. So the fastest impulse will dominate the rhythm. If you have ectopic sites within the atria that are going faster than the SA node, those are going to become the primary pacemaker. Oftentimes, when there's changes in the dynamics of the atrial structure, such as dilation or enlargement, new ectopic sites will pop up and take over as a pacemaker. There's also the re-entry, which is an impulse sets off an endless loop of depolarization, usually because it's initiated while some myocardial tissue is still in refractory. We'll go over this afterwards when we talk about SVTs. The first one is a wandering atrial pacer. So what that means, it originates or wanders from the SA node to various sites in the atria. Normally, with the SA node in a normal sinus rhythm, the impulse will take the same pathway through the intranodals, through the Bachmans. Every single impulse will take the same pathway. When you have a wandering atrial pacer, this creates a variety shape of sizes of P's, which means that sometimes the impulse travels slightly different because the change in your atrial dynamics or the structure might be altered. This rhythm can be regular or irregular. Your heart rate usually is normal, 60 to 100. Sometimes it might be bradycardic. Sometimes it might be tachycardic as we go into a tachycardic atrial tach. P waves will vary in size and shape. So they're all upright, they're all coming from the SA node, but they take different pathways. So again, what you're looking at is a different look of how the impulse is traveling through the atrium. The PRI will also vary, again, depending on how fast, which pathway it takes to get to the AV node. It may vary due to where that location of initiating in the cells. Your QRS would be normal because it did originate in the atrium. So you're going to have a normal QRS because it went down through the AV node into the bundles of His. Your QT should be normal as well. So the causes of wandering atrial pacer are usually due to an altered automaticity, sometimes increased vagal tone, which slows the SA node, common during sleep, often very common in COPDers, because when you have the change in the right ventricular pressures due to pulmonary hypertension, that right ventricle has to push against a lot of resistance. It causes the pressures within the right ventricle to increase. Therefore, it makes it more difficult for the right atrium to empty into the right ventricle and can change the dynamics or make the right atrium dilate. So those dilated hypertrophy atria will give a rise to increase in automaticity, and therefore you'll have changes in the impulse conduction system. The clinical significance, oftentimes there's not really any, and the management, again, normally you won't have any issues. It's just normal for some people. Multifocal atrial tachycardia, again, this is kind of where a wandering atrial pacer has now become a tachycardia. The wandering atrial pacer at a heart rate greater than 100, basically. Your treatment is focused on underlying pulmonary disease improvement, or your multiple atrial tachycardia usually coincides with improvement of pulmonary status. The patient may be getting nebulizer treatments that also increase heart rate. So it is very closely related to wandering atrial pacer. The rhythm usually is irregular, heart rate's greater than 100, and your P waves are varying in size and shape. You must have at least 3 different P waves in morphology to determine that it is an MAT, or multifocal atrial tachycardia. Your PR will also vary usually because of the different sites within the atria that the pathway will take. Some are faster, some are slower. Your QRS will be normal, usually because it is coming from the atria, and your QT would be normal. Here's another example of MAT. It's not in the book, but it kind of gives you an idea. The underlying rhythm is irregular, but there's, as you can see, there's arrows are pointing to tiny little P's that are in the T waves because this rhythm is going so fast. So it's very hard to determine what the underlying rhythm is, and to say that, oh, it's MAT right off the bat is really hard to make that diagnosis when it's going so fast. So you may even just call this an SVT, as we'll talk about that afterwards. Usually what's going to happen is these patients are going to have palpitations when their heart rate is up. And again, your management is to treat the pulmonary disease. Sometimes these patients may need to have a beta blocker or a calcium channel blocker to slow the ventricular rate down. We're going to talk about premature beats. It's also an ectopic beat that originates outside the SA node that usually occurs earlier than the next beat. So premature beats may originate in the atria, in the junction, or the ventricle. So there's 3 different types of premature beats. We're going to focus on the ones that originate in the atria. A premature atrial contraction, or a PAC, it's common practice to describe the frequency of the premature beats, such as rare, occasional, frequent. Rare would be 1 to 3 per minute. Occasional might be 4 to 6 per minute, where frequent is greater than 6 per minute. What it does is it creates an irregularity. So depending on how many PACs you have, if you just have one, you might have a regular rhythm, and then you have a premature beat that causes that area in the rhythm to be irregular, and then it may pick right up into a regular rhythm. And again, it depends on how many PACs you're having, whether it's going to make it look irregular or regular. Your underlying rate usually is what you're going to be calculating. And again, if you have a frequent PACs, it may increase the heart rate. Your P waves will pretty much look different. It may look a little different in the PAC because, again, it's coming from an ectopic site around the SA node, but taking a different pathway, and it's premature, so it will look, in your PR interval, may look a little bit different compared to the normal sinus rhythms. Your QRS is going to be normal or the same as the normal rhythm because it's still coming from the atria, and it's still going through the AV node and down the bundles of His. So therefore, you're going to have a normal QRS, and your QT should be normal as well. So if in this strip, you can see in this complex that you have a premature beat. This P wave looks slightly different than these P waves, and that's common when you have a PAC, especially compared to how close it is to the T wave. Sometimes your T waves will look bigger and the P's inside it, and you can't really see the P. So that's something that we're going to look at in this strip. So when you're looking at a premature beat, if it occurs very early, the P wave will be hidden in the T wave of the preceding beat. In this rhythm, if you look at the T wave of this beat compared to the other T waves, this one is bigger. And therefore, we know that there's probably a P wave in there. So that would be, and it's premature, so that would mean that this is a PAC. So looking at a premature beat, looking to see if there is a P, and if there isn't, look at the T wave to see if that P is hidden in there. So this is P in T. A non-conducted PAC, if PACs occur so early that the ventricle is still in its absolute refractory period, the ventricles will not respond to that stimulus, and therefore you won't have a QRS to follow that premature P wave. So in this rhythm strip down here, you have a P wave that came and it did not conduct down to the ventricle, so therefore you do not have a QRS. You just have a P wave. And if you were to do your P to Ps, this is early. So it is a premature beat. And again, if you were to map out your P waves, so this is a non-conducted PAC. Again, it could be missed. It looks almost like a pause, but you always have to look at the baseline as to see what else is going on to see if it is a non-conducted P. Sometimes you might see a P in the T, so if the T wave is bigger and you have this pause, it could be a non-conducted P as well. Atrial Bigeminy means that you have every other beat is a premature beat or a PAC. Trigeminy would be every third beat. Quadgeminy, every fourth beat. This gives a little bit more vision as to what's going on in that rhythm when you report, I have PACs in bigeminy or atrial bigeminy PACs. So this gives whoever the provider knows that you have frequent PACs every other beat. And these are PACs because you can see the P waves that are right before the QRSs. Atrial coupling, which means you have a couple of PACs, you can see, that are together. You have a sinus rhythm, and then you have two PACs, and then it goes back to sinus rhythm and sinus rhythm. And this would indicate that you have two PACs together. 3 PACs in a row is considered an atrial tachycardia. And that would indicate that this patient might be trying to go into like A-fib or a Flutter or some SVT. The cause of PACs usually is due to an increase in automaticity. If it's a non-cardiogenic, it's usually due to increased sympathetic tone. So stress and caffeine can cause frequent PACs and palpitations. Electrolyte imbalances and hypoxia are also causes of non-cardiac causes of PACs. Cardiac related would myocardial ischemia and any atrial enlargement where ectopic sites are popping up can cause that. An example would be like a congestive heart failure. Some other reasons, so without sometimes any apparent cause, you can have PACs. If they're infrequent, there's really not too much significance. If the PACs become more persistent and they are becoming more regular, they may lead to precipitate other dysrhythmias and require suppression, such as PSVT or SVT. So the clinical management usually is none is needed as long as it breaks on its own or if they're not too frequent. And if suppression is needed, eliminating the contributing cause. So if it's caffeine or alcohol, again, you may want to add beta blocker or calcium channel blocker or anti-anxiety meds may be used if needed if the heart rate continuously goes too fast or you're having frequent PACs. So remember, PACs are premature. They come early. If you're doing your R to Rs, they come early and then usually they come back with a pause. After the pause, they usually come back on time. They precede by an upright P that is different usually in shape from the sinus P, and it's always followed by a QRS unless it's a non-conducted, and it may have a non-compensatory pause, meaning that when it comes back on time, it's not exactly on time. Let's look at the following strips, 7.3, 7.46, and 7.54. Let's try to, why don't you pause the video, go through those 3 strips, and then restart the video, and we'll go over them again, and let's see if you can identify and recognize PACs. Uh, 7.3 on page 103, on page 104. In this rhythm, if you look, you have a PAC here, and you have a PAC here. You have a P wave, you have a QRS, and in this, you have it every 4th beat. So this would be quadgeminy, and it does not have, it looks like, a non-compensatory pause, so I don't think it came in on time. So that doesn't really matter too much, but just so you know, so you have 2 PACs, and you would document it as being quadgeminy because every 4th beat and the 8th beat it had a PAC. On 7-46 on page 118, in this one you have on the 5th complex you have a PAC. And note the aberrant conduction. When we talk about aberrant conduction, is that the impulse traveled down, but it just traveled down differently. So it's going to give a different looking QRS compared to what the other QRSs are, your normal QRS. But that's okay, it's common. But there is a P, it's premature, and it came early, and then it went right back to the patient's sinus rhythm. In page 121 on 7.54, this one looks different. So if you can see this PAC, it has, the P is all up in the T because it came very early, and it almost is very difficult to pick that out. But if you compare to what the other T waves look like, that's how you know that it's a PAC, because it does look different. And it is got a normal QRS, it's got a P up in the T, and let's see, the premature beat non-compensatory pause. So Huff frequently refers to SVT or supraventricular tachycardia rhythms as PAT, or proximal and supraventricular. Oftentimes has been interchangeable in her book. However, there is a distinct difference in how proximal and supraventricular are used in actually your practice. With paroxysmal, you have a starting and an ending abruptly. What you would see on a rhythm strip is the start of a tachycardia, and then you can also see where it ends. If you have a strip that is completely tachycardia, supraventricular tachycardia, you can't actually define it as paroxysmal because you can't see where it started and stopped. So you will hear us probably refer to the PATs that she's in, or the PSVTs, as supraventricular tachycardia or SVT, where SVT is kind of like an umbrella clause. So any rhythm that is in the atria that arise above the ventricles, because supra means above and ventricles again, so it's above the ventricles. So it would come from the SA node, the atria, or the junction, or somewhere within the atria. And we would define that as SVT. So proximal atrial tachycardia, or PSVT, is basically, as I said before, you see it where it starts and stops. SVT is, and you could say runs of SVT, which would mean the same thing as proximal or PSVT, but you're going to hear our terminology more often used as SVT. And if you use their ACLS guidelines, it's when the narrow QRS tachycardia is sustained at the site of origin is unknown. So your SVT could include atrial, junctional, AV node, re-entry tachycardia. We just don't know where in the atrium it is. It's going too fast to see, and you would need to slow it down in order to be able to see what the underlying rhythm is. I'm not going to go into too much detail, but understanding the re-entry. So there are thousands of conducting pathways through the AV node. What can happen is an ectopic pathway can occur that can get under the AV node. Normally, your AV node is the gatekeeper to the ventricles, and if your atrium is firing at a very rapid rate, the AV node will oftentimes stop many of those impulses so that your ventricular rate does not go too high. So if you have an extra pathway that is faster than your normal pathway, it can sneak around that AV node and be caught in a cycle. So premature beats arriving in the AV node may find some pathways that are still refractory and unable to conduct, and other pathways conduct normal through the bundles of His, and therefore you can have a cycle that's stuck in a re-entry and causes a very fast heart rate. In PAT, proximal atrial tachycardia, in this figure you can see that there's PACs on the fourth complex. You have a sinus beat, then you have like a run of PAT or PSVT. So you would have more than 3 PACs is going to be considered a run of PAT. And this would be legitimate to say that you can see where it starts and you can see where it stops. The rhythm is usually regular until it starts and then stops abruptly, and that's going to make it irregular looking. So you actually have almost 2 heart rates. So you can have a heart rate here on these PATs, and you have a heart rate that you would do for your basic rhythm. Your P waves will look abnormal in your PSVT, and it oftentimes is hidden within the T's, or you can't see at all if there's even whether it's coming from the sinus node or where it's coming from. So you can't measure the PRI within the PAT. Your QRSs will be normal because it is coming from the atrium and it is going down the bundles of His at the same time. Your QT is very hard. You really can't measure it because it's just going too fast. So you can't tell where the T's are ending or when it's on top of each other. Another example is SVT, sustained SVT. So anytime your heart rate is greater than 140, it's probably not in sinus anymore. So we call it SVT. To find SVT is your heart rate's greater than 140 and you have narrow or normal QRSs. That means that the impulse originated in the atrium. you will see that Huff often calls this rhythm as PAT, but it should be called SVT. You can't see if there's P waves, you can't see what the underlying rhythm is. It could be atrial fib, it could be atrial flutter, it could be a junctional, it could be a reentry, but you just can't see because it's going too fast. Causes most often is automaticity is increased, or if there's a reentry circuit, there's an extra pathway that the conduction is going down and getting under the AV node, such as in a reentry. So with increased sympathetic tone, so stress and caffeine can cause it. Hyperthyroidism can also cause SVT. Changes in your atrium, such as with dilation, and valve disease can cause a dilation of your atriums, and that will cause the structure change, and more ectopic sites will pop up, and more pathways can pop up, so therefore it can cause you to have SVT. And digitoxicity as well can do that. What the patients usually are going to complain about is complaining of palpitations. If most often in the young person, they can tolerate it for a while. Usually in the elderly, it makes it much more difficult to tolerate it because it does decrease the cardiac output, because with such a fast heart rate, you're going to have a decreased filling time, which is going to give you a decrease in your volume. So you have heart rate times stroke volume. So your stroke volume is going to be decreased. So if your heart rate's 170 and you only are able to move 15 milliliters of blood instead of 70, that gives you a 2.5 liters or cardiac output, where normally it should be 4 to 6. So that can eventually cause signs of unstable. So patients with PSVT can vary from slightly uncomfortable to very unstable. Any tachycardia that you have is going to increase the myocardial demand of oxygen, and that is problematic with any patient that has coronary artery disease, therefore that limits the ability to supply increased demand. And treatment is based on controlling the ventricular rate and converting the rhythm. With tachycardia management, you determine is the patient stable or unstable, so you can bomb it. And here is the tachycardia algorithm. If the patient is unstable, so you define that the patient is hypotensive, having chest pain, short of breath, is got congestion, is pale, diaphoretic, or change in mentation, that patient needs immediate synchronized cardioversion. If at all possible, you should sedate your patient because it is very painful to be synchronized cardiovert, more painful than pacing. Stable patient, you have some time. So with that, you can try and stop that SVT by blocking the conduction through the AV node. Oftentimes, the first thing you can try is vagal maneuvers. So with if there's an SVT and it only works in the atrium, vagal maneuvers only work in the atrium. So if they're stable, you can vagal, if you can remember that. It's the most non-invasive, so we can attempt vagal maneuvers. And if that doesn't work, you can try adenosine. And one of the following, if you know that they're having some kind of atrial fib or flutter, you can try a calcium channel blocker or a beta blocker. Eventually, they will possibly need to have elective synchronized cardioversion in a non-emergent situation. That would be much better in a controlled situation, and you can give sedation. In order to prevent any recurrence and to decrease that incidence, then definitely they would follow up some kind of beta blockers, sometimes electrolyte, and some patients may have to have ablations of the ectopic sites that are popping up. So they'll go into the EP studies, trigger sites that might be causing those ectopic pathways, and they will ablate them. Or if there's a reentry circuit, so they'll try to do an ablation to stop those circuits. With vagal maneuvers, you can do it with coughing hard, bearing down to have a bowel movement, squatting, holding their breath. You can do it if the patient's not able to cooperate. You may want to stimulate the gag reflex, or for children and young adults, you can use cold water facial immersion. That will increase your vagal tone or slow down your heart rate. And remember, if they're stable, you can vagal. If they're not stable, they're not going to be able to vagal. If they are stable and you have time, you've tried the vagal maneuvers, you're going to try adenosine. What adenosine does is it slows that conduction through the AV node where it completely blocks it, where you'll oftentimes see a brief period of asystole on the cardiac monitor. It is meant to convert SVT to normal sinus rhythm. It also, if the SVT is an A-fib or a flutter, it may diagnose A-fib or a flutter, and therefore you know that adenosine is not going to convert A-fib or a flutter, but it has diagnosed it where then they would be put on a beta blocker or a calcium channel blocker. If it is a re-entry, such as in a Wolff-Parkinson-White syndrome, which is a re-entry, the 6 milligrams rapid IV push over 1 to 2 seconds. You are pushing this drug in so fast and you're following with a saline flush right away because it has a 3-second half-life and it's already losing its potency in the IV. So you want to give this very close to the IV hub, to where the insertion site is. If there is no response, you can also give, after 2 minutes, 12 milligrams rapidly IV, again over 1 to 2 seconds. With that, you would definitely want to, if it does not convert, then they may want to have to do elective cardioversion, or if it's not a re-entry, then they would treat the patient with beta blockers or calcium channel blockers. The adverse reactions to adenosine is, as you can see, we added this. So the patient's in an SVT, you give adenosine and it's going to give a straight line and then they come back. What also happens is they can feel this. They oftentimes will have a feeling of pressure or chest pain. So you want to warn the patient. Don't tell them their heart's stopping or having a flat line on the monitor. Turn the monitor away from them, unless usually the nurses know what's going to happen. They may have some facial flushing. They may feel a little bit of pressure, but just remind them that it will subside very quickly, and remind them that, again, that this is a very short acting drug. So on the top one you have the asystole, on the bottom one you might have that asystole and then it comes back in underlying rhythm, if you look here, is an atrial flutter, and then the patient will go probably back into that rapid atrial flutter. So these are just examples of what you might see after you've given the adenosine, the asystole break, and then the rhythm will come back, and hopefully normal sinus rhythm. Or diagnose that they're A-fib or a flutter and then start them on a beta blocker or a calcium channel blocker. We're going to talk about atrial flutter. So with flutter, what you have is another site within the atria, that is ectopic site, is firing at a very fast rate. And what we call them is flutter waves or sawtooth. So you could have sawtooth or like camel humps. So with atrial flutter, the atria is depolarizing at a rate of 250 to 400 times a minute. Your AV node is under normal conditions can only conduct around 240 impulses a minute, and it serves as the protector to barriers so that you do not have a ventricular rate of 240, which is not conducive to life. So atrial flutter will often conduct at set ratios. So it might be every 4th beat, every 2nd beat. In these examples, the top one is every 4th or 2nd flutter waves. So these are conductions that are going on in the atrium, and then when the QRS occurs, that's when the AV node allow that conduction to go down. So with that said, you have your QRSs are normal because it's coming from the atrium. The flutter activity is continuous and distorts everything at the baseline. So on the bottom, you can see these flutter waves are causing like a sawtooth looking, and these are going to you can't tell, there's no P waves, you can't tell where the T wave is, so you can't do QT intervals. So it's very difficult. And this atrial activity is, again, they're not identified as P waves, they're identified as flutter waves in the sawtooth or camel hump appearance. The most common presentation of a new onset of atrial flutter is at a very fast rate, an atrial rate of 300 and a ventricular rate at least 150, if not more. In this slide, it's an example of how a fast heart rate at about 150. And if you cover the top and the bottom, what you'll see is this continuous flutter pattern going on underneath. And those are flutter waves. It's much more clearly if you slow it down. And there's examples in Huff on page 97 with the strip, another example. In atrial flutter, the rhythm might be regular or irregular depending on how many flutter waves to each QRS. So if you have a constant 2-to-1 ratio, or 2 flutter waves to 1 QRS, you're going to have a regular rhythm. Or if you have varying conduction, so if you may have 4 flutter waves and then 2 flutter waves and then 3 flutter waves, that's a varying conduction. So therefore your R to R will be irregular. Your atrial rate is 250 to 400 and your ventricular rate can vary. Your P waves, they're F waves, they're flutter waves. So you cannot measure a PRI because there's no P. Flutter waves are not a P. The QRS is normal because it's coming from the atrium, so you can measure that, and you can see that the QRSs are about 0.08 or so. The QT is not measurable because the flutter waves are masking the baseline. You can't see what's going on underneath. More examples of flutter waves. Going back to the slide previously, let's figure out how to determine the atrial rate. The flutter waves, which you can see as a sawtooth or camelback. So when you do a atrial rate, you would do it very similar to when you would do it in a ventricular rate by counting the small boxes between the 2 flutter waves and use the small box conversion table. So if you're looking at probably the top one, again, you can take your calipers and I would put it at the top of a flutter wave and to the top of another flutter wave and count how many boxes there are. And again, you can count how many boxes are there and go across. There looks like about 6 boxes. So that atrial rate up here is about 250. In the bottom, again, you count from flutter wave to flutter wave and see how many boxes between these are. And this looks like about 6 boxes as well, which would be 250. So your atrial rate or your flutter rate is 250. Your causes of atrial flutter, so if somebody's had cardiac surgery, it can change and pop up ectopic sites. Ischemia can do the same thing. Valve disease, because it changes the chamber sizes when you have mitral or tricuspid valve disease, and that will cause more ectopic sites to pop up. Pulmonary embolism, because of the pressure within the right ventricle, it can cause the right atrium to have increased pressures and change and ectopic sites can pop up. Also, alcohol intoxication. The problem or the clinical significance of atrial flutter is that you have a loss of atrial kick. Your atriums are going so fast, they're not actively pushing blood down into the ventricles. There's passively blood is going through the ventricles when the valves open, but there's not a good squeeze of the atrium, and so you'll lose about 25% of your stroke volume, which therefore will decrease your cardiac output. It also increases myocardial oxygen demand, especially in your fast rates. And because the inside of an atrium and inside of the heart is very porous, and if your atriums are not emptying, blood will pool within these porous areas and they can develop clots in the atrial chambers. So with that clot, it can actually become systemic and can travel and into your pulmonary artery and have a pulmonary emboli. Atrial fib. In atrial fib, the atrial rate is even faster because it's just firing from all over the atrium, and it can exceed 400 times a minute. It really can't be counted because it's too chaotic, and disorganized, and common for multiple ectopic, and reentry sites. The physiologic results of this is the atria that quivers but does not contract and expel the atrial kick. So again, with atrial fib, your atriums are just quivering. There's multiple chaotic ectopic sites that are firing, and it's going to look like a very fibby baseline, a very irregular baseline. Now, because the AV node is being bombarded with all these 400 conductions, impulses, oftentimes your ventricular rate will be very fast, and because of the chaotic impulses firing all the time at the AV node, the conductions will be delivered down the ventricles in an irregular fashion. So that will usually cause an irregular R to R, or regularly irregular, they say. If a patient has a heart rate greater than 100, we consider this A-fib to be uncontrolled tachycardia. It's irregular. Some providers may refer this to as atrial fib with RVR, meaning rapid ventricular response. Notice the hallmarks of the A-fib, which is a wavy baseline, and the irregularly irregular QRS rhythm. Most new onsets of atrial fib is a tachycardia because we have not provided that patient with some kind of blocking agent, such as a beta blocker or a calcium channel blocker, that gives the AV node the ability to slow down conductions down into the ventricles, and that's why we give a beta blocker or calcium channel blocker. So new onset of A-fib and A-flutter oftentimes are very tachycardic. Once we've given them some kind of beta blocker or calcium channel blocker, we sometimes overdo it. A-fib can present as a bradycardia as well, and again, this usually happens in patients who have been on drug therapy. We would have to treat a symptomatic bradycardia with bradycardia algorithm if the patient is symptomatic with this A-fib bradycardia. And again, find out medication reconciliation, find out what medications they're on, and stop those medications or decrease the dose. In atrial fib, the atrial beats so rapidly and erratically, whereas the flutter, the atrial beat is in a more organized manner. So that's why you'll have these same sequence of the flutter waves, because the pathway is taking on the same pathway. A-fib, there's firing from both atriums, bombarding the AV node, and it's completely at over 400 times, and you can't really measure it, but the ventricular rate will vary as to which impulses will go down the ventricle. Your P waves are not present, they're replaced with fibrillatory waves, so you cannot measure a PRI. Your QRS is normal because it is coming from the atria, and again, it is irregularly irregular rhythm. There's no rhyme or reason to it. You can't even get any kind of pattern, and that's what they mean by irregularly irregular. There's no type of pattern that is going to occur. Your QT is really difficult to measure if you can't see the T wave because of the distortion of the fib. But if you can see a T wave, it's usually good. The QT will be normal. Your causes of atrial fib, and it's extremely common. You'll hear AFib on many patients and frequently occurring in people without cardiac disease. In those cases, often self-limiting, converting spontaneously to normal sinus rhythms. So can occur in healthy individuals due to stress, emotional stress, excessive alcohol consumption, and it can convert back on its own to normal sinus rhythm. Other causes, you'll see CHF and hypertension or coronary artery disease or pulmonary disease. Again, with your COPDers or your lung disease patients, when they're if they have pulmonary hypertension, that right ventricle will change its dynamics and oftentimes develop cor pulmonale, or enlargement of the right ventricle, and that causes an increase in pressure within that ventricle, and the right atrium has to push against it. It changes the dynamics of the atriums, and therefore, especially with valve disease, and that can also have more areas within the atriums pop up as ectopic, and therefore it's faster than the SA node and it takes over as the primary pacemaker. Cardiac surgery is another cause of atrial fib, and the significance primarily is the loss of atrial kick. So with the loss of the squeezing and the emptying of the atriums into the ventricles, you can lose about 25% of your cardiac output or your stroke volume, which will therefore decrease your cardiac output. This also, because the atriums are just quivering, you're not emptying, it will increase your risk of mural thrombi. So the development of a clot within the atriums, which can become systemic and travel and be either, if it's in the right atrium, it'll go to your lungs. If it's in the left atrium, it'll go to your head, and usually you'll have a stroke with that. So it's very important to anticoagulate. But first, you need to control the ventricular rate. So clinical management is tachycardia management. If the patient is unstable, again, immediate synchronized cardioversion. So A-fib and A-flutter, if the patient's blood pressure is low, if they're showing signs of poor perfusion, we want to immediately synchronize cardioversion. If you can sedate them, that would be very nice. You'll have patient satisfaction scores that are good. If the patient is stable, you have some time, so then you want to consider which type of drug, some drug therapy, one of the following, such as a beta blocker or calcium channel blocker. If the patient has been in A-fib or A-flutter or feeling palpitations for over 48 hours, you definitely want to consider anticoagulation if in an A-flutter. So delay conversion of the normal sinus rhythm for 3 weeks to avoid risk of embolization. So if you have a patient that has been in over 2 days or so with palpitations, and they convert to normal sinus rhythm, that clot that was sitting in the atrium that was not emptying can break off and then be pushed down into the ventricles and sent either to the lungs or the head. So it is important to try and anticoagulate patients who've been in atrial fib or flutter greater than 48 hours. In order to, you probably, if it's been 3 weeks, they've had delay in their conversion to normal sinus rhythm, you can avoid the risk of embolization or by ruling out clots with a TEE, a transesophageal echocardiogram. When it's time to convert to sinus rhythm, you can use the elective cardioversion if the rhythm is present less than 48 hours, or sometimes using amiodarone if the rhythm presents less than 48 hours, or using radiofrequency catheter ablation. New onsets of AFib, patients may have less ectopic sites, and they could go in and potentially ablate those areas of ectopic sites and stop the atrial fib. Beta blockers, they have 4 cardiac effects. Again, you're blocking the sympathetic tone, and that's usually what a beta blocker does, and it decreases the rate of the SA node, so decreases automaticity. It does slow that conduction through the AV node, so therefore it will control the ventricular rate. And because it blocks the sympathetic, which with sympathetic stimulation increases contractility, it actually has a negative inotrope or decreases contractility. So it decreases automaticity for all cardiac cells. And so it decreases the excitability in a sense. The treatment is for SVT and ventricular arrhythmias, and the goal is to prevent reoccurrence of AFib after cardioversion. So they'll start people on beta blockers afterwards or before to make sure that they can potentially not go back into AFib. The problem or the adverse reactions of beta blockers is that it does cause bradycardia. Sometimes that dose needs to be adjusted, and because it is a bronchospasms can occur because you're blocking that sympathetic nervous system, because with sympathetic it dilates your bronchioles And what beta blockers do is that it stops that, and it can cause some bronchial spasms. So just be aware with those patients and be careful in patients that are COPD. Cardizem or verapamil, these are all calcium channel blockers. Cardizem is probably the most commonly used for a calcium channel blocker. And again, that decreases the firing rate of the SA node by decreasing the automaticity. It also slows down the conduction through the AV node. It also is a negative inotrope, so it decreases contractility because it blocks the calcium channels. So it's used to control the rate of an SVT or supraventricular tachycardia. And it also can cause bradycardia and hypotension because it is a vasodilator as well. Amiodarone, most commonly used for ventricular arrhythmias, but also can be given PO, post-cardioversion, to maintain sinus rhythm. So if it is a loading dose after a elective cardioversion, then you would load up the dose with 150 milligrams IV. Usually you put it in 100 of D5W and run it over 10 minutes, and then you would follow it with a drip. With amiodarone, it can cause hypotension. It can also cause a bradycardia, and the other thing that it can do is prolong the QT intervals. So therefore, it's very important to monitor the QT intervals when somebody is on an amiodarone drip. You will probably get parameters according to what the heart rate is when the physician will say hold amiodarone at QT longer than 0.46 or something like that. So let's recap. SVT is a sudden onset, very regular ventricular rate. The QRSs are normal because it's coming from the atrium above the ventricles. The heart rate is going to be between 140 to 250. Atrial flutter, your atrial rate's 250 to 100. You have a sawtooth or flutter waves, and ventricular rate will vary depending on how many conductions from each of the flutter waves goes down into the ventricles. A-fib is a wavy fibrillatory F waves. The QRSs are irregularly irregular. So let's do a checkpoint and do the following strips and complete the rhythm analysis, including QT intervals. Describe the appropriate treatment. Some of these have a scenario with them. So you're going to do 716, 717, 735, 757, and 776. So at this time, I want you to pause the video, complete all those strips in your practice session, and then come back and we'll review them. On 716, this is a regular rhythm. Now you can do an atrial rate and a ventricular rate. I'm not sure if you did that or not, but if you did do an atrial rate, the atrial rate came out to about 300. So there's 5 boxes between each of these flutter waves. So you have an atrial rate of 300, you have a ventricular rate of 100, and it is regular, so you can use the small box conversion table, or if you use the 6 seconds, you can only pull, this one is within that 6 seconds, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 times 10 is 100, so your heart rate's about 100. You do not have P waves, you call them flutter waves before each of the QRSs. So you cannot measure a PRI. Your QRS are measurable and they are normal. So if you measure from the beginning of the QRS to where the S comes back up, it looks like about 2 boxes, and that would be 0.08. Can't really measure your QTs because they're just flutter waves or masking your T waves. And if you were to interpret this, this is atrial flutter with a 3-to-1 conduction. In this 717, this rhythm belongs to a 76-year-old female who passed out at home. She's barely arousable. Her blood pressure is 72/70. She's pale and diaphoretic. Okay. let's look at this. You put her on the monitor and you see this rhythm. You see that it's irregular. You don't need a pair of calipers to tell that. So it's irregular. So you could use the not the small box, you would use the 6-second heart rate, and it looks like there's only 4 complexes. So the heart rate's around 40, ventricular. Can't tell if there's any P waves because don't make a P that's not there. So some people will try to say, is this a P wave? Is this a P wave? Is that a P wave? It is not. This patient is in atrial fib, so you have fibrillatory waves. You cannot measure a PRI. You can measure a QRS. So from your beginning of your QRS, measuring a couple of them, looks like about 2 boxes. So I'm kind of going here to maybe 2.5. This one's probably easier. 2 boxes. And so it's 0.08. You actually can, if you look, you can probably get a QT interval because the heart rate's so slow. But you know it's not less than half the it's not more than half the distance of R to R. So you're measuring from the beginning to the end, and it looks like it's about 10 boxes or 0.44, 0.4 or 10, 11 boxes. So the interpretation of this one is atrial fib. It is overly rate controlled, and we did this to them. So with this patient, are they symptomatic bradycardia? Yes, they are. So then you would implement the Brady algorithm. So you want to check their ABCs, IV, O2, put a monitor on them, administer atropine, 0.5 milligrams IV push. You can repeat it every 3 to 5 minutes up to a total of 3 milligrams. You want to potentially maybe implement transcutaneous pacing, because if there's no response to the atropine, which it may or may not, you can also try dopamine if necessary to support the blood pressure, and it also has chronotropic properties that can increase ventricular heart rates. So those are your Brady algorithms that you would attempt. In 735, this rhythm belongs to a 26-year-old law clerk who complains of sudden onset of palpitations, feels lightheaded and weak, nauseated, blood pressure 78 over 56. Now looking at this rhythm, it is regular and the heart rate is 188. P waves, you can't see them. They're obscured. You can't tell what's a T, what's a P, so you're just going to say, unable to see. So you can't measure a PRI. Your QRSs are normal, so if you do measure your QRS, you're going to measure from the beginning of the QRS, and then again, this has a little bit of ST depression, so it's kind of hard. So you would kind of get, it looks like about 2 blocks. Some of them looks even smaller, maybe 1 box, so it's 0.04 to 0.08. The QT, if you want to call that a QT, so it would be to the end, and that would be about, looks like 0.24. So what is your interpretation? If you look in the back of the book, it says PSVT. Well, that would be fine if you could see where it starts and stops. What we're going to call it primarily is SVT. And now, we want to assess our patient. The patient's assessment is showing, are they stable or unstable? If you said unstable, then you would be correct. So what would you do next? You would want to immediately cardiovert. If this patient is not tolerating, because they're young, you might want to try vagal maneuvers while you're getting the cardioversion. Sometimes you'll see adenosine used if this patient does have a history of a re-entry, so you might see them use adenosine, but this patient needs to be converted quickly because they do have a low blood pressure. 7.57, and this patient, the R to R is actually considered irregular. Your atrial rate, if you checked it, it's about 5 boxes apart, so that would be 300. Your ventricular rate is, I think it looks more regular, not irregular, excuse me. So the ventricular rate I think we got is 75. about 20 boxes in between. And you have no P waves they're not sinus, they are flutter waves or fib waves, or flutter waves or F waves. And there's a little bit of a varying in the ratio, but I don't know, it looks pretty regular as to about 4 flutter waves to each. Some look like they may have 5, but it's usually you say 4-to-1 conduction if it's a regular flutter waves. Your PR you cannot measure because there's no P waves. Your QRS you can measure. So from the beginning of the QRS, or there's no Q, but you're going to go to the R, and then you go to where it comes, the S wave comes back up. So it looks like about 2 boxes, 0.08. The QT is not measurable because your flutter waves are going right across. So your interpretation is atrial flutter with a 4-to-1 AV conduction. In 7.76, this rhythm belongs to a 68-year-old man who has had complaints of an irregular pulse and intermittent palpitations for the past week. Now looking at this R to R, it is irregular. Your ventricular rate is about 130. You cannot measure your atrial rate. There's nothing to measure. Your P waves are fibrillatory waves. And your PRI is not measurable because you do not have a P wave. Now your QRS, they are measurable. So you measure from the beginning of the QRS or your R wave to where your S wave. So I'm going to bring that up. It looks like about maybe 0.04 to 0.06. So your QRSs are normal. You can't measure your QT because they're all over the place and you have such a wavy baseline. So with this rhythm, it is considered atrial fib. The heart rate is 130, so this is uncontrolled A-fib. So what do we want to do about that person? We want to determine if they're stable or unstable. So it looks like the patient's just having complaints of irregular pulse and intermittent palpitations for the past week. So this patient's had this for a while. So therefore, we would probably want to anticoagulate this person before we do any kind of trying to convert them. So we would start them on an anticoagulant.